I must thank Dr. Bhandari for setting up the foundations for my talk, because so far we have been hearing about the telesurgery and we have been hearing about different multiple procedures and how they can be done. I'm going to change the pace a little bit. I'll bring you back to one disease on which I have been working for last almost 20 years, have done over 10,000 of them, and I still think it needs to be improved. And I personally feel that AI and possibly the telesurgery will make me better, and hopefully it will ultimately scale it down to almost everyone can get the results the same way expert surgeons are getting. That's the foundation of my talk, and I will start with thanking and acknowledging Dr. Srivastava, who is a legend, who is a visionary, and who is the reason why we are all in this room. Thank you, Dr. Srivastava. And I also want to acknowledge that he and Dr. Rawat and Dr. Ashok Hemal, who are sitting here in the room, were the awardees for the Golden Robot Award this year, last couple of months ago in New York City. So bring it back. It's not AI, it's not telesurgery I'm talking about a disease. A disease which is very common. Over 11 million people in the world are living with this cancer, and if you look at the population of Greece, it's exactly the same. The problem is that this cancer is not slowing down. The Lancet Commission recently estimated that there will be an increase in the number of cases of prostate cancer all across the world, and they use the word, a tsunami will hit this part of the world with the prostate cancer. Reason I'm focusing on prostate cancer is because that's what I do, but what we will learn in this operation, we can scale it down to other delicate operations, other delicate diseases. So that's the reason I want to set it up, that why prostate cancer was the first target, while Dr. Fred Moll, when he was presenting that, he aimed at the heart and ended up at the prostate. In year 2000, I was part of the first robotic case being done in Henry Ford Hospital with Dr. Menon, and we got successful. Reason prostate is an important organ is that it's very common, almost every man will have to deal with it in one form or the other. But this cancer is very sharp, very smart. It has an ability to kind of fool us, because so many cases of prostate cancer will be there, but not everyone will have a bad cancer. And this cancer can hide amongst a large pool of sheep, but there are enough wolves around, to the point that while we can treat and cure 95% of prostate cancers, 5% patients still die, and that 5% translates into 4 Titanic ships sinking every week. Large pool, small percentage of patients actually dying, but that number still is very big. So how to tackle it? That's what the challenge is, and the challenge is not just in saving those lives. Those 95% of the patients, those 11 million patients who are living with the prostate cancer, are not just always healthy. There are patients who are having complications intra-op, peri-op, that's a small number, but they live with incontinence, they live with a sexual function issue, and that's what 40 to 50% of the patients may have that problem. And one of the legends of the prostate cancer field, his name is, those who are urologists in this room will know, Dr. Walsh. And his main goal was that if we can reduce the sexual function problem in prostate cancer surgery, this will be a major, major milestone. And he devoted his entire life developing principles and techniques of doing in robotic, non-robotic, open radical prostatectomy, what he called a nerve-sparing prostatectomy. Till 2000, that was the way we were tackling it. And that may have been the reason that robot became such a useful tool in hands of a good, qualified, understanding surgeon, because this is one operation in which you don't get judged by what you took out. You get judged by what you left behind. And the margin of error is literally in millimeters in this disease, that on one side is a cancer lurking outside the prostatic capsule, and then very close are the nerves which are controlling the sexuality, which are controlling the urinary control, which are controlling the bowel movements, which are controlling the orgasm and everything. So The fact that the margin of error was very low and there was in competing goals for this operation, that's the reason even the open radical prostatectomy was not able to get to that point what robot got, because robot gave us dexterity, we saw that, but robot also gave us magnification. Robot gave us tools to go above and beyond what was being done, and that may have been the reason why robotic became a common tool, and now it can be expanded to the other things. But why there is an variability in an outcomes of an prostate cancer surgery even today? We have been doing the robotic surgery for the last 20, 25 years. Very good surgeons, very good teams, but the results, they vary. And that is where I think AI can help us to kind of making a great equalizer. The problem is prostate cancer is a multimodal problem. It has been with us for longest time, about 27,000 years ago when we had the first case of prostate cancer, and we are still trying to beat it. It is a disease which is driven by the cancer cell, but it is also driven by the volume. It takes about a couple of million cells before the cancer becomes about a centimeter mass, which can be seen on an MRI. It takes about 50 million cells. So the behavior of the cancer is driven by the cancer's own aggressiveness. It is also driven by the number of cells we are dealing with, and then it also is driven by the genes. Same word cancer, prostate cancer will behave differently if there are more bad genes, higher volume, or there is a more invasive cancer cell. Combining all that is not an easy problem for us to kind of navigate this journey, and I personally have been involved in this for the last 20 years. Somehow I got lucky about, in 1993, I was writing papers on the neural networks and artificial intelligence in prostate cancer. I didn't know that I'll be standing today.
Rashi Concierge VIP Company, WhatsApp audio.
They can still get me from New York here. So the phone works. And so basically, there are innovations in the neural networks, artificial intelligence, neuroanatomy, surgical techniques, and then finally, there is something happening in the co-pilot, and we have written multiple papers on each one of these topics. So what I will be talking about, that how my journey about being an early adopter of the AI led me to be where I'm standing today and talking about how AI can be a great equalizer for the outcomes. This is 1993, multiple papers written, talking about the imaging, talking about the genes, talking about the models, and now first paper about the ChatGPT on the prostate cancer, and then slowly navigating toward the 5G, which will ultimately lead us toward the telesurgery discussion. We have put together an electronic version of the PSA that if we can do this model, we can risk predict for an individual patient what's the likelihood that there will be a cancer. And this is where we started. Dr. Himal is a part of this paper that we wrote about the technique of the robotic surgery in 2003. And prostate cancer surgery is driven by understanding of the anatomy. We wrote multiple papers about the anatomy. And as you can see, the AI is helping us in understanding even the anatomy a little bit better. This is an AI-generated, AI-augmented model which is telling us that the stress during the surgery can have an impact on the nerves around the prostate. We have created the 3D models which tell us exactly where the cancer is. We incorporate all the information about the MRI, the ultrasound, the PSMA, and we have a digital twin. And we have created a compass which when we go inside the operating room, it tells me exactly where the cancer is trying to escape. It is on the left side at the anterior apex where the cancer is coming close to the edge. That is where we should avoid getting close to the capsule, and the rest everywhere else we can save the nerves. So we have this co-pilot being built in our own program. We have multiple computer engineers working in the department, and it goes through the entire process what we normally go through, and it gives us in a very accurate, very tangible, very actionable detail so as to how to modify the surgery in this particular patient. Prostate cancer surgery in 10 different patients will be of 10 different kinds. One patient will have a wider bladder neck. Other patient will have to deal with the median lobe. Third patient will have to have a extra facial nerve sparing. Other patient will have a hood procedure. So there are many variations which need to be managed to the particular patient's own diseases, and that's what this co-pilot. So this is an AI innovation. Second part, we got to know that the nerves which we are trying to save around the prostate, they are not just single nerves. These nerves are existing with the blood vessels, the fatty cells, the stem cells, the mast cells. They are existing within some kind of a supporting structure, and we call them as in compartment. So if we try to save the nerves alone, we are going to save the nerves, but these nerves will not survive. They will shrivel. And AI allowed us to understand that there are compartments around the prostatic capsule. These compartments need to be saved in entirety so that the nerves are not just saved, nerves are viable. And that may be the reason why there is such a variability in the different programs. Some patients have a function returned within 6 weeks, while the others we are waiting for 5 years. So this is what computer generated, but an AI augmented reality, that these nerves are traveling in a compartment and we can possibly tackle the whole compartment and not just the nerves. Coming on to the actual art of doing the nerve sparing, and I personally think that even an experienced surgeon can get better with an AI interventions. And as you can see, there are many things which can go wrong. We don't get to understand how much of a traction we are putting in, how much of an cautery we are using in, are we using the clip which is crushing the nerves. That all can be combined, and I'll show you a small example of how the good nerve sparing can start, but we can take it to the next level by incorporating some additional tools which I'll show in the next slide. It's literally an operation of delicacy. It's an operation of millimeters. On one side is the cancer, and other side are the nerves. And you have to find the right plane all the time, as many times as you can. And how delicately it is being done, and that's the reason the robot makes all the difference. We could do that with an open surgery, we could do it with a laparoscopy, but when you get down to a delicacy, I think it makes all the difference. But supposing you see the structures with the naked eye, but we have developed a method in which we can actually hydrodissect the whole system around the prostate so that we can see the nerves in much more detail. And there is no coded nerve system in this part of the body that tells us that this is sexual nerve, this is incontinence nerve, this is a prostatic nerve, or this is a bladder nerve. They are not color-coded. So as a surgeon, we have to decide which nerves are important and which nerves are not. And that's what we are trying to add into this equation. So we have done these models in which we can actually dissect it out around the nerves, and these nerves are literally like 3 of your hair. So that makes all the difference between the outcome. So we wrote a paper about how to develop this technique and all those things, and then we developed a couple of AI tools which give us an intraoperative methods for incorporating this diverse surgical information along with the patient's own unique imaging data. So this is what we are doing in an operating room to help the surgeon become a better surgeon. We call it an AI co-surgeon. It is giving all the unique information about the patient. It is sensing the all data point at the time of the surgery. It is looking at the images. It is looking at the MRI. It is looking at all the data points and then telling us where to change, where to tweak it out. So right now we have a tool which can tell us which part of the operation we are in. This is the beginning, and this is what we call, this is the bladder neck dissection happening, and this is the vas dissection, because this will help us in taking it to the next level and possibly having a co-pilot doing the important part of the operation by itself. We will see how it evolves. It can give you the force feedback. It can give you which plane you are in, and surgery sometimes is all about the plane. So it can recognize the tissue and color code that you look like you are in a good plane or are you getting too close to the cancer cells. This bluish changes in the color is because of that. If you're using a cautery, it will monitor that whether you're using too much of a cautery around the nerve or you're using the adequate amount of the cautery. We call it microzapping. You can actually histomap. You take the cancer out and 7 days later you find out that you left some of the cancer in the body, which happens in anywhere between 20 to 40% of the times. If this AI tool can tell you at the time of surgery that tissue which you are concerned about is actually cancer or is not a cancer, is an important tool. So we are training a model right now that area where you are concerned tumor is about 2.5 millimeter away. You're looking at the other area and you think that you came too close to the capsule, and it's telling it's actually a benign tissue. You look at the other area at the apex and you're concerned that are you at the sphincter? This was a benign gland. You can create a zone that gives you a heat map at the time of surgery that are you very close to the cancer or are you very close to the nerve? And based on that guidance, you can tweak it a little bit, one layer on the outer side or one layer on the inner side. This all is happening right now, but most important thing is, can we see the nerves? And these nerves are not exposed outside the prostate. They are hiding in periprostatic tissue, and and sometimes they are inflamed. And about 30% of the time, cancer is coming outside the prostate to intermingle with the nerves. So with that background, I want you to see that this is what it takes for a normal surgeon to find the nerves. And nerves are hiding somewhere here. But supposing there is a way that you can color code the nerves at the time of surgery, like green color you're seeing here. And beginning surgeon can also identify that these are the nerves, and that can be saved. You can color code the nerves with an AI intervention that where the nerves are, and then you can not damage them. You can float the nerves within water jet so that that's the least traumatic way, and then you can do it when you can see that the nerves are. This is all being done with an AI telling you which structure is what. You can see here that you can actually see the nerves in a greener color. These are all experimental models right now, but we hope in next couple of months or years this will become in common practice. If this can happen, this will avoid damage, and this is that delicate nerve which we talk about it. Can we save it or can we not? If we can identify it, we can save it. And that may be the reason why we have a good results in most of the cases. We are developing a model in which a model looks at the whole surgery and it predicts what's the likelihood that the patient will do well. Because at the time of surgery, we don't know 6 months later patient will be having a sexual function or not. But if we can train a model which has been done on the 500 videos whose outcome at 6 months we already know, and then can train the model, then it can tell the actions which you're doing are looking good, or you may want to tweak it a little bit here and there, and that's what we need to think about it. So before I summarize, I want to say that the AI models are going to make the surgeon a little bit better by being more prepared. So there will be a co-pilot or a digital twin which will go to the operating room with the surgeon. Second part, in next few years, there will be a part in which a robot will say, hey, can I take over this part? And you don't need to worry about it, dropping the bladder, doing certain part of it, and you just be around to supervise. We do that with the residents all the time. And then the third part may happen, and I'm sure it will happen, that it will be done by the robots. So all that foundational work is being done now, today, by the surgeons in this room, and the technologists, and the inventors, and the dreamers who are in this room, that it is going to happen, and basically it will give an access to almost everyone who needs a surgery, whichever part of the body it is, whichever part of the world they live in. So this is the best equalizer. Thank you very much.